President Trump just unveiled the Great Healthcare Plan. It's a framework, short on legislative detail, aimed at lower drug prices, lower premiums, and more transparency. But here's the part that decides everything. The plan proposes replacing government health insurance subsidies with direct payments to consumers. Basically, here's money, go buy your own healthcare. And it's dropping right when marketplace costs are spiking. Reuters reports average premium payments projected to rise from $888 in 2025 to $1,904 in 2026 after enhanced ACA tax credits expired. That's not a small bump, that's a budget earthquake. Proverbs 11:1, a false balance is abomination, but a just weight is his delight. If the numbers look good only on paper, somebody's getting shorted in real life. America, here's why it may not work. It's not a plan yet, it's a framework with missing load-bearing beams. Reuters and the Washington Post both note the rollout is light on legislative text, timelines, and operational detail. That matters because in healthcare the devil isn't in the details are the healthcare. And in Washington that's a lot of pork and Trump has eliminated the oversight agencies. Remember, it's just framework right now, not bill text. Let's be honest, the White House released a one-page proposal and called Congress to pass it, but there's no bill text and no timeline. The plan says it will lower drug prices, lower premiums, boost transparency, and hold insurers accountable. It also calls to codify most favored nation drug price deals and expand over-the-counter access. Traditional rule of thumb, if it isn't written into law, it's not a plan, it's a press release wearing a suit. Luke 14:28, count the cost before you build. Healthcare doesn't run on vibes. Healthy exit lead to premiums rise. Here's why the direct cash idea can blow up. Insurance markets survive on risk pooling, healthy and sick together. Reuters notes critics warn direct payments could push lower-income Americans toward less comprehensive plans outside the ACA marketplace, undermining the marketplace structure that's meant to keep premiums down. When you turn automatic premium support into money in your account, many healthier people think, I'm fine, I'll skip coverage for now. Then who's left? People who need care, meaning the pool gets sicker, meaning premiums rise. That's not a conspiracy, that's math, cold, ancient, and undefeated. Micah 6:8, justice and mercy matter because policy choices land on real bodies, real families, real emergencies. The centerpiece risks breaking the ACA marketplace, subsidies and HSA deposits. The plan's biggest pivot is replacing ACA subsidies with direct deposits into HSAs. That sounds pro-consumer, but it collides with how premiums and human behavior actually work. Look, cash doesn't automatically become coverage. ACA subsidies today reduce premiums at the point of purchase. It's built in. A direct cash model creates a new problem. People can delay, skip, or repurpose the money when life hits rent, car repair, groceries. And health insurance is the thing people plan to get next month, until next month becomes next year. A Cornell Health Policy Center expert survey flags this risk plainly. Direct subsidy money could lead some often healthier people to not enroll, increasing adverse selection. Sicker pool, hiring kranen dan, sicker bursen to debt my kan bottom. Barid dan insertions, higher diary donor one premiums as a dead bond. Timing mismatch, premiums are monthly, life is messy. Even if the deposit equals the subsidy on paper, the user still has to pick a plan, pay reliably every month, manage paperwork and churn. That is friction, and friction reduces enrollment. Old school lesson. The more steps you add, the fewer people finish the job. In other words, more work for you. It's a Epstein distraction. Why HSAs favor the people with slack money. HSAs can be great if you already have spare cash. Multiple analyses show HSAs tend to be more attractive and beneficial for higher income households because the tax advantages are worth more in higher tax brackets and higher income groups are more likely to have these accounts. Now, combine that with high deductible plans. For a family living paycheck to paycheck, consumer choice can become choose which bill doesn't get paid. James 5:4. God hears the cries of people getting squeezed by unjust systems. A plan that works only for the comfortable isn't a fix, it's a filter. HSAs mainly benefit people who already have spare cash. HSAs are great if you can afford to fund them and choose a high-deductible plan. But lower-income households often don't have the slack cash to ride out a $6,000 to $10,000 deductible year. Reuters notes critics warn this shift could push lower-income people toward high-deductible or short-term plans, the short-term plan trap risk. If the policy lets people use those deposits for non-ACA compliant coverage short-term plans, you get cheaper premiums for healthier people, thinner coverage and underwriting workarounds, sicker people left in ACA compliant plans. ACA premiums rise. That's market fragmentation, and it's the classic way insurance markets unravel. Geographic plus age pricing can make deposits insufficient. Premiums vary massively by age, region, and local hospital pricing. If deposits aren't tightly indexed to benchmark premiums by county and age, you get a voucher that's generous in one area and useless in another. Fraud and eligibility administration becomes a new battlefield. Direct cash benefits attract fraud and administrative complexity. If it's easy to claim, it'll be abused. If it's hard to claim, people fall through cracks. Either way, enrollment and stability suffer. MFN drug pricing. Big promise, big landmines. The plan calls for Congress to codify most favored nation drug price deals. Could that lower prices? Possibly, but MFN has a history. CRS explains courts rejected the rushed good cause pathway, and CMS later withdrew the MFN interim final rule. Translation: if it's not built with durable law and clean rulemaking, it gets tied up, delayed or undone. Ecclesiastes 1:9, there's nothing new under the sun. We've seen big drug price moves run into legal reality before. MFN drug pricing has a long history of legal and implementation landmines. The plan leans on most favored nation style drug pricing. But the 2020 MFN model faced court blocks, and CMS later withdrew the interim final rule. CRS explains how courts rejected the good cause shortcut and how the rule was pulled. So will it work depends on rulemaking durability, APA compliance, how MFN price is defined and calculated. CRS notes newer EO language didn't define the MFN price clearly. Manufacturer responses, access restrictions, launch delays, contracting shifts. PBMs plus kickbacks could raise premiums. End PBM kickbacks sounds like a slam dunk until you follow the money. Brookings warns that forcing rebate pass-through can fail to reduce payer costs, and can even increase them if it weakens negotiation incentives. Axios reported a real-world example where moving away from rebates could lower out-of-pocket drug costs but may mean higher premiums, because employers lose rebate offsets. So the trade-off can be cheaper at the pharmacy counter, but pricier every month. Proverbs 11:1, again, honest weights. Don't promise savings if you're just moving the bill to another pocket. PBM kickbacks reform can easily raise premiums while lowering copays. This is the part that sounds like a guaranteed win, until you follow the money. Brookings notes rebate pass-through policies can fail to reduce payer costs and can increase them depending on negotiation incentives and market structure. Axios has a concrete example. Cigna moving away from rebates is expected to lower out-of-pocket costs for some patients, but could mean higher premiums because employers lose rebate offsets. So it can work, but as a trade, lower pharmacy counter costs. Higher premiums often spread across everyone. Transparency. Good. But often, data dump theater. Transparency is right in principle. CMS already requires hospitals to post machine-readable files and shoppable services lists, but Reuters has warned that some transparency pushes can generate massive, unorganized data that doesn't help normal patients shop. And studies have found compliance has been incomplete in practice. So yes, transparency helps, but only if it's standardized, enforced, and actually readable. 1 Corinthians 14:8, if the trumpet gives an uncertain sound, who prepares for battle? If prices are incomprehensible, who can plan? That's not a free lunch, it's moving the check to a different table. Transparency is good, but it historically underdelivers without enforcement plus usable tools. Reuters reported transparency rules. What would make it work? The guardrails or premium spike. So, will it work? Parts can help, CSR funding and certain drug price actions could reduce costs at the margins, but the plan risks failing where it matters most because it turns structured coverage support into consumer cash behavior, right as premiums are already spiking for millions. If Congress wants this to actually work, the guardrails must be explicit: deposits indexed to real local premiums, age plus county, automatic premium payment, opt-out, not opt-in, tight rules on using deposits for skimpy non-ACA coverage, strong risk adjustment reinsurance to stabilize the pool. Micah 6.8, Justice and Mercy. A healthcare plan should protect the vulnerable, not test their balance sheet. The blunt verdict: the plan is most likely to not work, because it risks destabilizing the insurance pool by turning automatic premium support into optional consumer cash behavior, while leaving key guardrails unspecified. CSR funding and some drug pricing pressure could absolutely produce savings, but the subsidy redesign is the part that can blow up enrollment and premiums. What would need to change for it to actually work? Deposits indexed to benchmark premiums by county plus age, not flat amounts. Automatic premium payment from the account, opt-out, not opt-in. Strict limits on using deposits for non-ACA plans or you invite adverse selection. Explicit protection rules: pre-existing conditions, essential benefits, out-of-pocket caps. A stabilization backstop, reinsurance, stronger risk adjustment. If you want more deep dives that cut through the slogans, subscribe, drop a comment, and share this with someone staring at new premiums this year. If those guardrails aren't in the bill, the great plan becomes the great premium spike plan.